all of us know that your successes come on the backs and the learning from many, many risks and, and challenges, and some might even say failures. Let me start with one question for you, a thought-provoking question I think you raised, which is, if failure is the key to success, then how do you decide how much risk to take? And, some might argue, Parag, that, building yourself as an orthopedic surgeon, a leader in so many fronts as you have, it doesn't come without taking some risk. How do you decide on that risk balance ratio? Because it is difficult, right? To explore and innovate, you need to take some risk, but risk comes with some failure. How do you balance that? And how would you guide others in their own practices to be thinking about risk?
I think that's a great question, Mohit. And always, whenever we are doing something outside the comfort zone, outside the safety envelope, that risk is always there. And I particularly, whenever I feel that, I'm getting outside the comfort zone, we usually have a strategic group at the hospital, and this is the professional risks I'm talking about, where we brainstorm and we talk about, what can go wrong, what's the worst case scenario, what's the bailout option, what is plan B if plan A fails. And as long as there is some backup and the risks you're taking is not going to be an irreversible problem, as long as you have the cushion to absorb the risks if everything doesn't go your way, then you're safe. And I think that has to be a calculated decision. You cannot take decisions just by your intuition. Of course, in the end, your sixth sense and the intuitive power does help, but that should be at the last. You've got to take a scientific and a calculated risk, knowing fully what you're getting into, knowing exactly what can go wrong, and having a complete plan B if things do go wrong. And at times, there is always, one of my colleagues says that, a very thin line between bravery and stupidity. So if you really succeed, then you're a brave person. But if you don't, then people say, oh, how stupid that guy was.
Yeah, that happens
I
all the
think
time, right? Yeah, that
happens
happens
all the
all
time.
the
So I
time.
think
Yeah.
you've got to really take it, and I feel it should be a informed risk. It should be a
Yeah.
calculated risk where you know what's going to go wrong and what's the worst case scenario. So, and at times you've just got to jump in, and believe me, one learns to swim.
Absolutely. And you talk a lot about, so, okay, you take some risk, right, in your practice. In this particular case, you talk about sort of knee surgery specifically. And you have, let's say, an outcome that was unexpected, or one that you thought, okay, it could happen, but now it's happened. The one thing I've always been impressed with, sort of the great leaders of our time has been their ability to look back carefully at the data that led to that, and then really try to understand it. We call them routinely around the world as M&M rounds, right? The mortality and morbidity rounds. Parag, can you speak a little bit, maybe for some of our, and if there's anyone else here who, speaks to the types of ways in which they evaluate complications and how the team learns from the complications. Can you speak a little bit about the processes that you've put in place or that you've seen that could be considered the gold standards for how we should be conducting these sorts of evaluations routinely in our practice to get better and learn from our mistakes?
Absolutely. I think so. All these cases which I showed you, Mohit, let me be very honest, they are real cases. And, I have each case I have analyzed, I have studied, and I have become a better orthopedic surgeon. I think what you said also, the mortality morbidity meetings, what we also do in these meetings, it's a very, very closed door meeting,
Yeah.
and I always say that whatever is discussed in that room cannot be discussed outside,
Yes.
not in the elevators, not in the coffee room, never again. And I think
Yes.
that's how you learn. You have to have a team which believes in each other, which has the trust in each other, and is ready to accept those mistakes. And I think the first step to improvement is to accept that you made a mistake. And if you always feel, no, 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 it wasn't my mistake, the bone was too osteoporotic, the vessel was very sclerotic, oh, my assistant pulled the retractor so hard, it's always easy to pass on the buck. But believe me, if you do that, you will make the same mistake again. So the first thing which my father always says is the acceptance. You accept that you made a mistake, and then if you accept it publicly, believe me, that requires more courage. So these M&M meetings we have are always divided into two. First we present the cases, we do it on the the second Thursday of every month, Mohit. So next time you're there, you can attend it.
I will.
And
Yeah.
after 35 to 40 minutes, it's 1 hour session. 20 minutes I just spent on how not to do these things again. And then we talk to each other, we confide in each other, and learn from those lessons. So I think discussion and going retrospectively into that cases, and mulling over the cases, what went wrong, is something which is important to make sure you don't make repeat that complication, I think. And complications will happen, because a surgeon only who doesn't operate will not get complications. So one should not get bogged down by it, but one should understand why it happened. And Dr. Ranawat always tells me, Professor C.S. Ranawat from HSS New York, that you should have the ability to understand what has gone wrong. And
Right.
believe me, whenever we are operating, if something goes wrong, your assistant even might not know, but you know that, okay, you pulled that nerve a little hard,
Yeah.
you cracked the bone, you've done something which in
Yeah.
your mind, the MCL has been over released, but you just at the time just push it under the carpet, hoping that, no, you will brace the patient and that MCL will heal.
Correct.
But believe me, that comes back. So if you identify the mistake on table, be bold, declare it publicly, and then do something for it there and then. If you think it will correct itself, the chances are more often than not it won't.
Understood. That's actually a very good point. Are there any questions from anyone who's in this group? We'd love to hear from you, either about how you've been evaluating your own patients, or questions you might have for Dr. Sancheti. And while you're thinking of some, or if you want to make a note of it, let me ask Parag another point, which I think came up very, very, I thought, poignantly, which is, and I'll state it this way, and then I'll let you respond to this statement, which is, you can't help heal others until you heal yourself. And I think about this so much about, there are many of us, especially in the last 18 months, I think in the world, we've all felt the sense of burnout and, and stresses that we've never had before. And we had many, many of our frontline surgeons, workers, healthcare providers, right at the brink of being on empty with respect to their battery. How do you refuel, and how important is it to make personal well-being a priority so you can ultimately be the best you can be when you're managing patients, managing your trainees, you're educating, and also ultimately having less complications?
Absolutely, Mohit. That's a brilliant question. And, again, I would like to quote your sister Shivani. So, because we are the people who are always faced with people who have problems, who have kind of negative energy. So, unless we heal ourselves, if we also exude negative energy or negative thoughts, then that's not going to help. And I'm a firm believer that if you're a healer, as you rightly said, first you need to have healed yourself. And what do you mean by that? By that we mean that whenever we meet patients, we have to give them, positive thoughts, positive energy, kind of empathize with them, not sympathize with them. I feel empathy is the way to go. Be compassionate with them, and definitely, apart from your scientific treatment, what you are going to advise, that specific treatment, that is fine. But in addition to that, you need to go that extra mile. You just need to put your hands around the shoulders of your patient, give him a pat on the back. Don't worry, this is something what has happened, it's not good, but this is going to get well soon, this is going to be behind you, or whatever it may be. You just got to be one with the patient, and I feel that is very important. And how do I get it, how do I deal with such situations? I am a strong believer in the grace, or in a God. And every day morning I pray, I do meditation before leaving my home. And as you have seen, we also have a temple in the hospital. And I'm not religious, I'm not, feel that you have to do it. Each one has to find their own way. I'm not saying everybody should go to the temple or go to the church or meditate. You've got to find, how do you connect with the grace, how do you connect to the mother nature, how do you connect to that supernatural power. And this is very, very personal point. Just because something helps me, that doesn't mean it will help you or anybody in this group. It is a process which evolves itself, and through experiences, through your own stories, you learn. And I think, for me, praying has helped, meditation has helped, And there's one more thing which I can tell you. Sometimes when I'm stressed, I just reach home and go for a long walk.
Yeah.
And I'm just to myself, just thinking,
Yeah.
mulling over.
Yeah.
And I call it, whenever there's a complication, I call it a one-nighter, two-nighter, or three-nighter. And the worst I've had is 4 nights of lack of sleep.
Wow.
So,
Wow.
so it shouldn't get you more than that, because that is the time when, these kind of things, having a mentor, doing meditation, prayers, connecting to the grace, at times I've connected with you more. So you've got to really talk to people who you can trust, whom you can confide into, and all these things collectively make you a positive person, and then you can definitely heal your patients.
Right.
So that
Right.
is what I feel is my way of dealing with stress, and exuding positive energy to the patients and healing them.
Absolutely, and I think you're right. I fully support your assertion that however we find ways to keep ourselves healthy and mentally well will only help us in managing patients, and ultimately, as you said, managing the day-to-day issues of the challenges we face with the care of patients. So I fully agree. I see a question here from Joseph Silver. Joseph, did you want to have a quick question you wanted to raise?
Yeah, I thought maybe I'll start off the questions if there's nobody else. So thank you for
Sure.
the very interesting talk. I really enjoyed it. The one sort of common theme that I got from it is from your mistakes. It seems it's very necessary at times to tell the patient no, and that you really should not operate. But that has its own set of challenges in communicating that to the patient. And so how hard do you push in saying no? And, if you ultimately decide that you're not operating, how do you mediate what happens next in terms of, do you pass them on to a new surgeon, or dealing with that whole process? Thank you.
So that's an excellent question, Joseph. So there have been times when we know that this patient actually doesn't need to be operated, and he probably doesn't deserve the surgery, but sometimes the patient has taken multiple opinions and has come to you with a mindset of surgery, like one of my patients who had a stiff knee, and actually I could have just left the patient alone, but that pressure is there, the peer pressure is there, and you don't want to let the patient go. So but I think, if at that particular time, if you feel that in the best interest of the patient, uh, surgery is not required or not indicated at that point, I think we have to tell the patient, even though the patient doesn't want to hear that. And the patient may actually go across the road to your colleague or to a different hospital and may get operated, and but then so be it, as long as you are convinced and you have the evidence to back it up, that okay, this surgery is probably not required. I think you should be upfront and tell the patient. And then you can always tell the patient that when he goes, that okay, let me see you in 3 months time, 6 months time, and if then things don't progress, we can always come back and take the decision of surgery. So I think explaining him the various pros and cons, and telling him that this is what can go wrong after the surgery, and then making a combined decision. I think the decision for surgery always has to be from both the sides. It should not be one-sided. But once you touch the patient with your knife, as I showed you in my slide, actually it's your responsibility then, because look at the amount of trust the patient is giving to you. He's getting anesthetized, he's coming to the OR where, the patient's life is in your hands, so to say. You're allowing you to put a scalpel. If you do that, doctor doesn't do that, you know what it happens. It's like a murder or police case, and you get arrested. But then he's giving you the chance, the opportunity to put the knife on him. So when you are going to do that, that has to be with a full understanding that the patient is only going to benefit, and that's the best thing for them. But if you feel that's not what it is, then I think, with my 26 years of experience in practice, I have learned to say no to the patient. And we have some Indian friends here, whom I can see in the audience, because in India it's a little different. The patients have a choice of going to wherever they want, unlike in Canada or in North America or in the US, where probably they are, confined to the region and to avail hospital care in that particular hospital. So for us, the pressure is more because they might just go across to somewhere else. But then I think, just to end, I would like to say that if you are convinced surgery is not the way to go, be upfront about it, tell him, and he will appreciate it.
Right. I think we have
Thank you
time
very
for
much.
one more question. I think there's another Joseph. Joseph, did you want to unmute and ask your question?
Yes, I do have a question. As you can see, I'm in a hospital bed. I'm actually living through a complication, and I have a very good, straightforward, concerned and caring physician. So it's the right route to get. They're taking that message, and I think your message you gave today was great. The thing I was concerned about, which I've experienced, and I'm sure a lot of people have experienced this, is when you see a patient with an infected joint that wasn't your patient. And infection itself may not be an error because it happens to everyone, but it's the denial by another surgeon about the infection. They're saying it's something else because they don't want to, maybe it's because they don't want to deal with it, or they don't want to admit that they get infections. Is there a way to get a message to the other people about that infections happen, and the best thing to do is not deny it and face it right up front?
Absolutely. So I think once there's a complication, you have to, admit it, accept it, and tell the patient upfront. Because if you tell them, no, it's just a superficial infection, don't worry, and you put him on some antibiotics, it's not going to work. Because if you know the infection is deep and it requires something additional, some other procedure to be done, it has to be done, And if you don't accept it, the infection is going to flare up, and then probably it's going to be too late. So something, a stitch in time saves nine, they say. So accept it, and probably you can salvage the infection if
आपने
you pick it
पीसी
up
बंद कर
early.
लिया?
But I think just extrapolating from what you are saying, it suffices to say that if there's any complication, don't put it under the carpet. Face it upfront and deal with it. Like Professor Ranawat always says that if there's a complication, accept it, and there is always a chance to correct it. There are very few complications which have irreversible trends. Suppose if there's a popliteal artery injury, you've done a surgery, it doesn't heal, the flow doesn't develop, then the patient may get gangrene and lose his limb. But then that's a very, very rare scenario. Most of the times the complications are reversible, or if not completely reversible, at least you can deal with them. So to answer your question, if there's an infection, accept it, and there's always going to be some chance of infection. It's not that there is a 0% chance of infection. So the patients also do understand that once you diagnose the infection, there are ways to treat it and overcome that infection. So acceptance of the complication or the issue you're facing is paramount to treat it.
Great. Thank you very much. Thank Joseph for that question. We have come to the end of this session. As usual, great thank you, Parag, for your insights, your honesty, and certainly the guidance you've provided, not just to us in this small group, but I think to many hundreds and hundreds, and I might even dare say thousands around the world who have benefited from your interactions and your leadership around the world. Everyone else, thank you so much for taking time. I wish you the best in the rest of your day. Thank you very much.